So hello everyone and welcome to another ODwire webinar. It's Adam Farkas along with
Paul Farkas here.
And tonight, Paul, it's all about ocular surface wellness.
Wellness.
Yep.
Right.
And so I know that you know a lot about the ocular surface. It basically formed the core of your practice back in...
I caused many of the diseases.
That's correct. So we're going to do something a little bit different today. You know, we're going to actually talk about wellness as opposed to whatever you did way back when. So the idea about wellness, and I'm sure everyone's noticed this, that healthcare is moving to this model where patients are taking a lot more control of their own healthcare and being proactive and trying to actually keep themselves healthy before they get sick, because by the time you get sick and have a problem, obviously it's a little bit too late. And clinicians are starting to make this shift as well. And so tonight's talk is all about how in your own practice you can promote ocular surface wellness. And importantly, we have an expert tonight, Paul, so it's not just us.
Okay.
Thank goodness.
Thank goodness, that's right.
We have Dr. Kelly Nichols, and if that name sounds familiar, it should. She is the dean of the University of Alabama at Birmingham School of Optometry. So we have a bona fide expert with us here tonight, and she's going to tell us all about ocular surface wellness and how to integrate these concepts into your own practice. So I hope everyone is awake and alert and ready to go, because Kelly's got a lot of great information for us tonight. So Kelly, thanks so much for being here.
Well, thank you. I appreciate being invited to be here. This topic is a really interesting topic to me, near and dear to my heart, so it's my pleasure to be here with our audience out there to talk about ocular surface wellness. As was mentioned, I have recently moved to the University of Alabama at Birmingham. I'm the dean at the School of Optometry. I came via University of Houston, where my husband and I were for 3 years. We both together created and developed an ocular surface translational clinical research center and managed to do a number of studies in contact lenses in ocular surface in primarily disease. So I would say we kind of focused on the disease part, as our medical model generally promotes. But I do, if you notice, in my degrees here have a master's in public health. So all while the concepts of ocular surface wellness, or the wellness aspect and prevention, have always been meaningful to me, even though I haven't had direct answers of how we can solve this problem. The concept of wellness and how it might relate to what we do day to day is really important. This is a sponsored program by Alcon, and not so much that it's promotional in nature, even though the slide says it's promotional. Alcon has made the commitment to try and understand and to promote ocular surface wellness as one of their key initiatives, which I applaud them for. They would like it to be a global initiative and to involve the knowledge and interests of other industry leaders and companies in order to bring them on board, so that it's a group effort, because as you see as we go through these slides, no one person, no one group can create the concept of wellness and have it live in our practices. We all have to do that together. And I do again applaud Alcon. I am sponsored by Alcon to do this project, and I've worked with them as we develop the Ocular Surface Wellness Initiative. And hopefully it will be an initiative that grows, much like some of the other industries unrelated to eye care, how they've had wellness initiatives. I hope that we can do the same here. We will not be talking about too many products. In fact, this is mainly just educational. This lecture will bring about more questions than answers, but it's intended to be thought-provoking, as prevention generally is, so that you can start to incorporate these concepts into your practice and determine how it might best fit your needs as a practitioner as well as the needs of your patients. I guess we have to start, and I know this slide isn't really projecting real well, but we need to start by talking about what wellness is. It's hard today to understand wellness because we so typically think of sickness and what lack of health might be. And wellness is both being healthy or being in good health, but it also has an element to accepting and promoting good, healthy behaviors. That's a little bit more difficult in our environment because there seems to be so many things that press on us that are bad behaviors. So certainly creating good eye behaviors is something we rarely talk about, but should do so more so with our patients. We can start by doing that actually though with our own staff because if we all agree in the small community, sort of a grassroots level, that wellness is important to a practice, then you can start from sort of the ground up to build wellness into your day-to-day activities. This slide I think is really important as we set out talking about ocular surface wellness in general. To understand prevention, and this slide really illustrates prevention from a public health perspective, where there's primary, secondary, and tertiary prevention. And I'm going to spend a couple minutes here talking about this slide because I really think it sets the foundation. Primary prevention from a public health standpoint is the reduction of the incidence, that's new cases of disease. And to do that, you need to understand what the root cause of a disease might be so that you can get to it before it actually ever happens. So the goal in primary prevention is to prevent the initiation of the disease process. Now, already your brain is probably whirling thinking, well, in ocular surface conditions, many of them, we don't know what the root cause is or they're multifactorial conditions. Well, you can start to chip away at some of those factors, and there may be some things that we can do that will aim or target primary prevention. But where we're really probably focusing mostly in our current environment is at secondary prevention. Some good examples, however, of primary prevention include vaccination efforts, having healthy habits, and not necessarily even smoking cessation, although you could call that primary prevention in terms of lung cancer, etc. If you prevented smoking from happening in the first place, that truly would be primary prevention. So activities that are aimed at keeping teens from smoking, etc., would be good primary prevention efforts. Secondary prevention is what we would like to call early detection, and that may be earlier detection than what we usually do in our day-to-day practice in terms of disease identification. Usually this occurs before any symptoms occur, so you may be looking for, and this is an example, dry eye disease before a patient would complain of it. We do this every day with glaucoma. We're looking for signs of glaucoma before a patient would notice a reduction in field, because by that point, you know, we've really missed the boat. We're too late in the game. So things that are targeted towards secondary prevention are screenings, routine checkups, and then when you do find something, early intervention rather than let's see how it goes, but targeting an intervention early so that you can have the best effect long term. When you get to the point where you're looking at tertiary prevention, you've kind of gone too far. I mean, we hope not to get to this point, but what that does is improve the outcomes. It's detecting disease and managing it appropriately, and sometimes that comes at managing it in a very late stage of disease and can be called rehabilitative care. Generally, you're trying to, in tertiary prevention, aim at doing things like control so that you can have a better outcome, a better quality of life, or keep or maintain the status where you currently are at rather than deteriorate further. So a good example of that would be adequate glycemic control for diabetics. And you could say perhaps nutritional supplementation for AMD, although I think that's a tiny bit of a stretch. In what we do every day, we hope to achieve primary and secondary prevention, and in the instances where we find disease that has been very severe or has come on very fast, we aim for our best efforts at tertiary prevention. Wellness today is a very conventional model where it is detection of disease and interaction with the medical system to regain health, not so much to maintain health. And this is a problem. If you stop to think about wellness and your own personal health care, usually you'll go to the doctor when you're sick or when you think that there is a problem. Very rarely do you go to the doctor so that you can discuss efforts at maintaining good health. I was thinking about this today, about going in for a routine physical. Just moved to a new place. I have a new primary care provider, and I want to get to know my primary care provider, so I made an appointment for a physical. Haven't had it yet. But all the while I was thinking, what are they really going to tell me? This is my, this is what most people probably think about. What are they really going to tell me? They're going to tell me that I'm fine. Maybe I can improve a little bit of this or a little bit of that, or maybe my cholesterol should be a little bit better. I should exercise more. But all in all, I'm healthy. That's what I might think to myself. That's probably what a lot of people out there think about their health. I would venture to say that not a single one of those people really thinks about how their eyes might be healthy before they actually have a problem. Eyes are something probably that we really do take for granted and have to think about more on a daily basis. And so training our patients to have this approach, a wellness approach, is going to be a big step in trying to incorporate wellness into our practices. But it is a problem that when we interact with the healthcare system, whether it be as practitioners or as patients, it's really to regain health or to fix something that's wrong. And that has some elements to do with how healthcare is financed, and certainly it also has to do with that the diseases that impact us today are more chronic in nature. Some studies say that we are in the midst of a chronic disease epidemic. Generally, countries that are not developing, certainly those that are established countries, do deal with chronic diseases more than those that are developing countries. And a lot of costly chronic diseases are linked to what we would say are modifiable lifestyle factors, but they're those in which we tend to ignore from time to time. So this is part of the reason why wellness is difficult, because it requires change, behavioral change, and maintaining those behavioral changes that can be truly a challenge in today's environment. It is thought that approximately 75% of U.S. healthcare dollars are spent on managing chronic disease, and if we could reduce that even a little bit, our costs on the healthcare system would be significantly reduced. There is a wellness movement, though. You do hear about individuals who are supporting concepts that are non-Western, quote-unquote, non-Western ideas, or using complementary alternative medicine. In the next few slides, you'll see that listed as CAM. A lot of our healthcare expenditure costs, well, a rising amount of our healthcare expenditure costs are coming from these sorts of services and products. And so there are many individuals who are starting to embrace these ideas of prevention, mindfulness, mind-body connection. And if you look at the green circle that's on the right there, and you get an idea of what that is, you'll see there's also an element of spirituality in there. Exercise, rest, development, personal growth, etc. And I want to sort of separate out the wellness movement from what would be considered early detection or prevention from a little bit from the spiritual or the spirituality concept that you often hear when you hear about complementary or alternative medicine concepts. I think that we tend to lump all that together, and it may indeed be separate. Conceptual ideas that are related to wellness don't have to just be around things like yoga. So I think we need to kind of try and help our patients understand these differences. If a patient is willing to consider or discusses or practices alternative medicine approaches, then they likely will be more in favor, though, of a wellness movement related to the eyes. And so it may be that, asking a question or two about that can help you gauge as a practitioner where your patient might fall down or fall in concept with acceptance of this overall idea. Wellness truly is a partnership, though. It's going to be a partnership between many groups. It's going to be a partnership between providers and patients, the medical system as a whole. There may be those that are not practitioners that get involved in terms of wellness concepts. All of this, though, will require a change in behavior, and changing behavior is very difficult in concept. And as practitioners, we may be worse at that than others. We tend to be set in our ways, do things the same way, and it's hard for us to break out of that mold, especially when you have a routine that you utilize on a day-to-day basis in terms of your exams and how you interact with your patients. So there has to be desire from both the patients and the practitioner as well. The patients are wanting information and desire to have good recommendations from practitioners who they trust. So involving these concepts in the routine care and discussion with the patient will be, I think, the grassroots way moving forward. A good example of this in the literature is what dermatology has done over the years relative to skin cancer. Now, there are a few things on this slide that I want to point out, though. We do know that one of the main risk factors for skin cancer in general, is sun exposure. So you can directly link through study after study that the length of time that you're exposed to sun, the number of sunburns you had as a child, your amount of pigment that you have in your skin, if you wore sunscreen or not, all of those things are factors that are involved in your risk or maintaining a low risk profile for sun exposure and then skin cancer. So primary prevention would be sun avoidance. Well, that could be readily achievable you might say. However, we're all outside all the time. We spend a fair amount of time, my family and I, in Australia, and they have some very different rules there relative to sun exposure. Of course, the ozone layer is very thin there, and you can get a sunburn quite easily. And in most of the places, it's a fairly temperate environment, so they're outdoors a lot. Very much do Australia, they very much cover up. So children outside, if they want to go out to recess, they have to wear their hat. And their hat has to cover their ears, so it has to have a broad brim or have flaps that come down over the ears. And oftentimes, even in warm weather, when Australians are outside, they'll wear long sleeve shirts so that they can prevent exposure. Always they wear the rash guard sort of swimsuits, and often they'll wear long pants, or they'll not often as much wear shorts. So they are very much a society that has accepted that modifying the risk factor of sun exposure by wearing clothing is a very achievable aim. Secondary prevention then would be early detection. So often in today's society, we may go into the doctor to have our moles or any irregularity in pigmentation evaluated, but not everybody does that. Certainly, though, it's becoming much more accepted that if you have an unusual spot on your arm that's pigmented, you should go get it checked out. And then it is also recognized that secondary prevention or early detection has much better outcomes. And there's been many, many studies to support that. Now, primary prevention for skin cancer prevention began in the 1930s, but it wasn't until more recently that we started really adopting sunscreen all the time. I remember when I was in my teenage years, we would put on baby oil or very low number SPF oil so that we would get a good, good sun tan. Sometimes it was a sunburn that would turn into a tan afterwards. From that time forward, we've become more and more accustomed to using sunscreen, and now you see SPF 50. You wouldn't go out to the pool without putting it on yourself and your child, passing it around to your family, even your family who might not have worn it all the time growing up. My family, my parents, now they'll put on sunscreen even though they never did their whole life until now. We know that skin cancer is the most common cancer in the U.S., so certainly targeted approach towards skin cancer prevention was a big deal to dermatologists in terms of helping to reduce the skin cancer incidence that they were seeing. And now it's become something commonplace. Certainly, if there were more screenings that occurred, it could even help to reduce mortality. Some studies have been shown to bear that out as well. Well, if we try to switch and translate that concept into ocular surface wellness, it may not be quite that easy. Certainly, we know that there are many things that are associated with ocular surface conditions. There are several ocular surface conditions we're going to talk about tonight. Dry eye, meibomian gland dysfunction, ocular allergy, contact lens dysfunction are all conditions that are thought to be related under the large umbrella of ocular surface, anterior ocular surface disease. Likewise, all those would then be related in ocular surface wellness. So the prevention of any of those conditions would be considered something that could be a wellness campaign. We know that many of the conditions I just mentioned, even though it's unclear how rapidly they might progress, if you ask 100 people if they thought they were practitioners, if they thought they were progressive in nature, although perhaps slowly progressive, most practitioners would say yes, they are. They can't necessarily link who would be more progressive than which patient would be more progressive than another patient, but in general, it is accepted that they tend to be progressive conditions or worsen over time. So, given that we can wrap our brains around that concept that they're progressive, any prevention efforts would be welcome. So, early detection, such as secondary prevention, could be very effective. But how do we screen for these conditions? Are we doing that before the conditions occur? We have patients that come into our offices, and often I've been even guilty of not doing anything for them unless they're complaining about it. So if they're complaining that their eyes are irritated, well, then maybe I'll do something about it. But I can even think as recent as 10 years ago where if a patient kind of had some eye irritation, you didn't think that they were going to be willing to actually put artificial tears in, maybe you just wouldn't even mention it to them. Or you wouldn't spend a lot of time actually trying to encourage them to do it. I take a different approach now. The earlier I find it, I talk about prevention in that I don't want them to be the ones that I'm having problems with 5 years or 10 years from now. So if the earlier you talk about it, the better off you are at catching it early. Perhaps you're preventing a negative outcome on the tail end, the end that you can't see right now. And for that reason alone, I think it's worth to do early screenings for these conditions, which may mean asking a few questions or doing a few tests in your routine eye exam as a screening for, as a technique for early detection. Recently, I've been involved, and again, this is coming back to Alcon, with a concept of ocular surface wellness. And in February 2014, a group of key opinion leaders, about 50 of us, got together to start talking about what ocular surface wellness might mean and what it could look like. As we tried to think about how practitioners and patients alike might accept this concept if it was meaningful and we could promote it in a way that would change our practice and change our practice patterns for the better and reduce the incidence in new disease as well as find early disease and keep it from getting worse in the long run. It was the beginning of a discussion, hopefully a very long discussion. We had individuals there from the dermatology field who helped to discuss what happened in dermatology that created sort of that mind change or behavioral change so that now we all use sunscreen routinely. We had dentists there as well who talked to us about how incorporation of the wellness sort of exam and dental cleaning has become so commonplace that we go 1 or 2 times a year, and we often, we're ready to go. We're ready to have our teeth cleaned so that we can prevent cavities, but more that we want the clean feeling in our mouth. We want that healthiness that we get when we go to the dentist. And the dentist comes in and says, yep, great, you've spent the entire time with the hygienist. But all in all, I don't know if you've noticed, I notice much more now, even more recently, that they're also looking for cancers. They're overall taking care of the body in addition to the mouth. So they're looking for mouth cancers, throat cancers, they're looking at the way you bite and looking for signs that you might have stress. A whole bunch of different things that weren't involved in a dental exam previously are now included in a preventative approach to dental care as well as skin care. I think that the eye is a wonderful parallel to that, and ocular surface wellness really was the concept that we were talking about relative to can we model what we've seen in these other health professions to create sort of a campaign for ocular surface wellness to help prevent some of the negative outcomes that you'll see should ocular disease or anterior segment ocular disease occur, like dry eye. So when we all got together, we were trying to come up with a manifesto statement or a definition to speak about what ocular surface wellness could mean. And some of the words that you see here are what we came up with. Ocular surface wellness, we felt, was a prerequisite for ocular comfort. So if your eye was healthy, you were going to have a comfortable eye. Your vision then would be clear because all the elements that provide that perfect refractive surface to the eye would be intact and stable and provide clear vision. And importantly, from focus groups, we heard from patients that healthy looking eyes were really important. So oftentimes, I think that patients are willing to sacrifice comfort in some instances to have eyes that look healthy. Think of some of your contact lens patients. They will suffer with discomfort just so they can wear their contact lenses because they feel their eyes look better or their face looks better while they're wearing contact lenses. Healthy looking eyes also came up in terms of redness, where patients would report that they didn't like it when their eyes looked red, and you all have had patients who have come into your practice and said, I don't really notice my eyes feel bad, but my coworkers tell me that my eyes look red. I look like I've been up late or I've been crying. My eyes are red. Can you help me with that? So we felt that a concept of ocular wellness included the sort of holistic approach of a healthy looking eye as well. Now, to achieve that, it has to be promoted through engaging eye care practitioners, so letting people know that this concept should be something that we should be developing in our practices. But importantly, it also involved the patients as well as the public. So when we talk to the dentists and we talk to the dermatologists about how these concepts were embraced in their professions, public awareness through education and awareness activities really sort of stood out as something that we should consider in terms of how we can continue on this approach, because it really did take sort of a village in order to, over time, it took a village and it took time in order to raise the awareness that was needed to have the prevention activities be accepted. Now, our goal in the long term would be to preserve the ocular surface health so that all of these other things, comfort, vision, healthy looking eyes, would be able to occur throughout throughout the time that we are alive. I mean, we want our eyes to be healthy and we want our vision to be successful until we no longer need our vision. So our aims were to protect ocular surface health, which is a primary prevention role, to detect early stage disease, so that would be secondary prevention, and from a tertiary prevention standpoint to help to optimize function, minimize symptoms when conditions were identified. And that would be a tertiary prevention activity. So maintaining quality of vision, ocular comfort, healthy looking eyes also translates into successful contact lens wear, successful glasses wear, and successful surgery should you need a surgical or desire a surgical intervention. Now, many of these things are addressable, but there are some things that are not. But it all starts with the practitioner initiating a conversation with the patient about healthy eyes. I'm going to go through a few of the elements that I think resonate fairly strongly with practitioners and patients. Of course, patients come to you because they want to see well, and generally many of them have good vision when they come in to see you and expect to have that same good vision when they leave, as well as over the next year, 5 years, 10 years. So our efforts generally in optometry have been focused to detect or prevent, and slow any pathology progression to help preserve vision. In terms of optimal vision, the tear film has been shown to have a significant effect on image quality. There have been some unique studies which have looked at the retinal image quality when patients have held their eyes open and not blinked, so the image is being, the image of the retina is being videoed, and as patients keep their eyes open and the tear film breaks up, haziness of that image occurs. So certainly what that means is that if you are the person viewing through that haziness, you can expect a decrease in your quality of vision. Now that can be transient, and that's often what our patients report, is that when they're looking at the TV at night, they have to blink a lot, or they're trying to read small print on their iPhone and they have to blink several times. They have to make sure they get in good light so that they can better see because their vision's transiently blurry. That should be a red flag to a practitioner if patients are talking about any of these things and difficulties in viewing. If their vision is being compromised, and it could be related to the ocular surface, we may be actually screening for wellness in a way, or lack of wellness, by just listening to them throughout an eye exam as you're refracting them. So there are some small things that we can do that we're already doing. It's just listening, or asking a question a bit differently, paying attention to how we optimize vision, and looking for that as sort of the red flag, as perhaps a sign that vision may be compromised, therefore the ocular surface or the tear film might be compromised. We do need to optimize the tear film in order to have the best effect afterwards. It is estimated that approximately 37 million of people in the United States wear contact lenses. Many of those are patients in your practices, and certainly you've been taking care of them, hopefully for a long time. You have new wearers every year, and it's harder to calculate the number of wearers that have fallen out of contact lens wear. But they're there. They're silently there in many instances. They've started wearing their glasses, or they've slowly over time reduced their either hours of lens wear or the number of days a week that they wear their lenses, so maybe now they're only a special occasion lens wearers. It's hard to kind of wrap your arms around why patients fall out of lens wear, but the number one reason that patients fall out of lens wear is discomfort and dryness. The second most common reason that patients fall out of lens wear isn't the symptoms of feeling something on their eyes, it's their vision. So taken together, if a patient has discomfort and they're having visual problems, that's almost a surefire sign that they're going to just quit contact lens wear, probably in fairly rapid succession. Patients, again, like I mentioned, are willing to put up with discomfort sometimes if they have adequate vision. So if you have a patient that can see well and their contact lenses get to be a little bit discomfortable or uncomfortable from time to time, they're going to tolerate it. And actually, women are more likely to tolerate that discomfort than men are. Men are, I think, maybe more likely to quit, studies have shown. But contact lens dropout is a big deal for all of us. If we can keep our patients in contact lenses longer, we'll have a more robust practice of contact lens wearers. Patients generally are pretty happy when they're successful in wearing contact lenses. So one of our goals with this whole process was to look at the contact lens wearer and try to optimize their vision and comfort to prevent dropout. We know that there are age-related changes that we see to the tear film. However, the tear film is a very robust system. I mean, we have 70 meibomian glands in each eye. We have one lacrimal gland, but together that system should be relatively robust in maintaining the tear film, but sometimes it goes wrong. Does putting a contact lens on the eye actually make it go wrong immediately? Those are some of the questions that we're trying to answer. Or is it slowly over time? What are the triggers? But we do know that keeping wearers in lenses would be a beneficial outcome for all of us. This graph sort of demonstrates that. The sort of turquoise blue at the bottom where it says contact lens wearers, that's the group of lens wearers over time, and you see the age along the bottom of this slide. So your young wearers, your 20 to 24-year-old group, have the highest, well, they're not quite the highest in percent of the population. That occurs at about age 30 to 34. But look what happens after the age of 30 to 34. It starts to slowly decline as wearers drop out of lens wear. Now, if you could keep them from dropping out, the graph would look more like where you see that gray arrow. It would just continue to grow up. So our number of contact lens wearers in their 50s would be much higher if you could keep them from discontinuing lens wear after the age of about 30 to 34. So as you start to think about reasons about why a patient might drop out at that age group, why would that be? Well, one of the reasons could be because they're unhappy with the type of sort of multifocal lens experience they might be having. But certainly we have some new lenses now. There's daily multifocals. There's a variety of different options that were not available previously to us that we can utilize. Still dropping out. So you kind of have to look around to see what else might be at play. We do know, so in the top part where you see that dark blue, that's refractive need, but you also see that as time goes on, the dry eye and as dry eye and presbyopia progressive, there's certainly more refractive need, but less contact lens wear and more ocular disease. So is it the ocular disease that's keeping people out of contact lens wear? Well, not everybody who wears contact lenses has experiences dryness enough to want to drop out of lenses. So there's still a lot we don't know. But we know if we could find discomfort or the root of discomfort earlier, we might be able to halt the number of patients who are quitting contact lens wear. So another switch to this, or another element we like to consider, are the patients that are undergoing ocular surgery. And they can undergo ocular surgery for a variety of different reasons. They can have refractive and cataract surgery, they can have glaucoma surgeries, retina surgeries, and nearly any type of surgery that you can think for the eye has some involvement on impacting the ocular surface, whether it be through the surgical procedure itself or through some of the medications that patients might be using after the surgery, either way, or inflammation because of the surgery. Any way you look at it, all of those conditions could potentially have a better outcome if, both visual and otherwise, if there was some preoperative assessment, and not only preoperative assessment, if there was preoperative management. So this is a really good example of when you could use some early detection or even primary preventative techniques in order to optimize the outcome at the end. If you look at these two images on the right, you can see the top images of rings that are shown onto the eye from a topographer, and the image on the bottom, you can see that there's quite a bit of distortion and blur, and even if you've never even looked at this sort of pattern, because you're looking at the tear film, you can appreciate in the lower image that the tear film is quite irregular. So there's a lot that we can tell even through a simple technique. You have a patient come in, you're looking at them in terms of if they'd be a good either refractive surgery candidate or a cataract surgery candidate. You do topography, you see the ring images that look like the lower image, and there certainly is something to address. in terms of preoperative management to get a better postoperative effect. And there's been quite a bit of study on what the percentage of patients that come in for these types of surgeries and what their ocular surface looks like. The bad news of it is that quite a few of them have some form of ocular surface disease, I mean. And then if you also look at patients post-LASIK, a lot of the time they are LASIK candidates just because they are unsuccessful wearing contact lenses. That could be because of dryness and irritation. Now maybe they just don't like wearing contacts, but for all of these reasons, the optimizing the vision in an ocular surgery candidate is sort of low-hanging fruit. It's something we can easily achieve, and there have been a number of ways to do that. There have been a number of studies on certain medications, certain artificial tears, which will improve that, but certainly the first step in that in prevention is detection. So what should you be doing in terms of screening? Well, you certainly are doing a screening of the ocular surface pre and post-op. We do want to ensure that we are looking at the tear film. The tear film is the primary cause or thing that you can look at related to some visual aspects, the transient or fluctuating vision, symptomatology, ocular surface, damage as in staining are all things that you can evaluate when you're looking at ocular surgery candidates. Having the discussion with them about ocular surface wellness, though, before they are scheduled and go on to that surgery is important because the patients need to buy into it as well. They want to know why they might be doing something different than they have before, and certainly the concept of better outcomes might mean something to them, and that might be proof enough, or convincing enough. But certainly if you can begin in engaging them in this sort of lifelong concept of ocular surface wellness at the stage where they're preparing for surgery, they may continue with that after the surgery. Comfort is something that we've talked about a lot in the Contact Lenses Comfort Workshop, which is a TFOS-related activity. TFOS is the Tear Film and Ocular Surface Society. Over the years, there have been a number of international, we call them workshops, and I've been very involved in these workshops, which have looked at things like dry eye, contact lens discomfort, and meibomian gland disease, and all these things related to that and how they're all tied together. In each of these situations, a large report has been written by the groups of people who have worked on these reports, and they're very, very didactic. I mean, they end up giving some good advice, but they're intended to be sort of the status of the field as it is right now. Most recently, the Contact Lens Discomfort Workshop talked about ocular surface comfort and felt that it could be best described as the absence of any sensation, negative sensation on the ocular surface. So if you stop to think about your eyes right now, can you feel them? Are you aware of them when you blink? I don't know that patients have. We've tried this with patients to see if we can, if they respond well to this sort of questioning, and they don't. So asking them if they feel their eyes, they're like, what do you mean? Of course I feel my eyes. It's right here in my head. That's not necessarily what we're trying to get at with that question. We want to know if they have an awareness of their eyes when they shouldn't, because in all reality, you shouldn't feel your eyes, because if you do feel them, then you're experiencing discomfort. We know that discomfort can come from a variety of sources: medications, dry environments, computer use, visual tasking, other factors, and certainly asking these sorts of questions is commonplace in a dry eye exam as well as a screening exam, like perhaps your comprehensive exam uses a survey that asks about some of these questions. Go back to your practice and take a look at how you're asking these questions and see if you can't refine that a little bit with the concept of wellness in mind. And it does take a little bit of proactivity in order to engage your staff to do the same. Now, I mentioned that patients like to optimize their appearance. Of course, everybody wants to look the best that they can. And what that means to patients is they hope for white, quiet eyes that don't look puffy, with healthy lashes, and if you spend any amount of time watching TV or the ads, you know that the lash industry and the cosmetic industry is alive and well. Certainly women are hopeful to have beautiful eyes, beautiful lashes. Now, some of the cosmetics that our patients can use can actually create some eye irritation, and so having that as part of your discussion in terms of ocular wellness can be a small step at long-term discussions related to maintaining the health of the eyes. This lovely lady in this image right here has a fair amount of makeup on, you'd all agree. Is she getting that all off at night? Maybe it's not such a big deal that she wears it during the day. However, if you look really closely, she's got that black eyeliner all the way up and clogging up all over those meibomian glands. If you've ever had a discussion with a teenager who has black eyeliner over top of her meibomian glands about how that might be causing some discomfort, you know it's nearly a showstopper. It can be done, but again, you have to think of prevention as something that takes steps over time, and certainly with some repeated efforts, it will start to sink in. And like I've gone over a few times here, looking good may be as important to patients as feeling good. If you have that contact lens in and you're happy with how you look, you may be able to tolerate some discomfort. Now, our goal as practitioners would be to minimize any discomfort that a patient might have and increase their possible longevity while wearing contact lenses. Keep them healthy, have them feel good, and have them look good at the same time. There have been some studies that looked at video education related to teenagers with sunscreen use and the risk of cancer. And the study found that it was much more effective to show the teenagers images of wrinkles and sun-exposed skin, sunspots, etc., and as a effort to encourage or promote sunscreen use than it was to talk about the risk of sun cancer. Or skin cancer relative to sun exposure. So it kind of goes to show you that even teenagers are affected by how they look, and if the thought of wrinkles to them is a really bad thing, I don't know how we can translate that into ocular surface wellness or eye health, but certainly these concepts could be something along the lines that we use if sort of these direct-to-consumer kind of approaches are used in the future. We all use our devices way too much. All the time we're on computers. We're doing it right now. You may be actually on your computer and your phone at the same time, or maybe there's a TV going on in the background. So we are constantly looking at things and using our eyes in ways that we never did before, and so are young people. Many times I get asked questions about ocular surface health in kids and teens, and if I've noticed an increase in dry eye and meibomian gland dysfunction in our youth, and I have certainly seen more and more young people coming in that have dryness. Now, from a preventative standpoint, the mom might say, well, I'm not going to be able to get Johnny to use an eye drop, and I'll have a discussion with the mom. Well, you would hope to try, because long-term from now down the road, if we don't try and address this now, it could only get worse, and there's a lot of years left in life. So I think that the earlier you can target some of these, especially in our youth, may be worth considering. Allergy. It's allergy time of year right now, at least it is where I am. Today, I checked the phone this morning when I was getting ready to go outside running. It was 98% humidity. It was only 70 degrees, but the pollen count for weeds was off the charts. So all that little pollen is hanging in the humid air and creating quite the world of pain for many of the people who live around Birmingham. It is seasonal, many would say, although there are plenty of your patients that experience ocular allergy year-round. Allergy affects 15 to 40% of the U.S. population. Of that, many of those patients have ocular allergy associated with their allergy condition. So with the patients who have ocular allergy, it can range anywhere from itching, dryness and itching together, or just difficulty during certain times of year, perhaps in wearing the contact lenses. So patients that I see out of season, I'll call it, I try to have discussions with about prevention, knowing when that season's coming along. What is the patient going to do when that season does come along? Are we adequately medicated? Do we try and avoid situations which might provide more pollen to the eyes? And when that eye exam does not coincide with allergy season, this proactive type of questioning can be really important. Maybe even a note to follow up at the right time to sort of increase or encourage ocular surface wellness. If you think it from the dental point of view, they're encouraging routine cleanings that would perhaps cover all the seasons that could be irritating to the teeth. Now, there isn't really a season or an equivalent to ocular allergy in the mouth, but certainly the regularity of the exam can help. So consider appointing patients to come in more frequently if they are known to have conditions which could affect ocular surface wellness. I spent a lot of my career thinking about meibomian gland dysfunction and blepharitis, and certainly it is quite prevalent among our patients that we see, more so than we probably ever thought. And why is that important? I think that over the past 5 to 10 years, we've seen an increase in our evaluation skills of patients who have blepharitis and meibomian gland dysfunction. It's not that it wasn't there before, it's just now we're writing it down and paying more attention to it and trying to manage it a bit more aggressively than before. I think it's truly from a prevention standpoint. If we can address blepharitis and meibomian gland dysfunction earlier, certainly we're going to have better visual outcomes, a more stable tear film that can lead to a more appropriate outcome from a surgical intervention. Some would say that eye care practitioners see dry eye and blepharitis in approximately 40 or higher % of patients. Some studies show that patients have, that in some practices, nearly 100% of patients have Demodex. So I think that our awareness of the lids and the lashes has really helped our ability to be preventative and to discuss concepts that are more along the lines of wellness and prevention in our patients. However, that does take time. So you have to be sure to make sure that you are appropriating your staff to be able to handle some of this so that you're not having to do this all the time as well. Blepharitis, we know, is associated with a number of inflammatory eye conditions, and meibomian gland dysfunction may be the most common cause of evaporative dry eye. So is MGD dry eye? In some ways, yes. You know, evaporative dry eye is the largest subcategory of dry eye disease that we have. We know that contact lenses in surgery could be considered as threats to ocular surface wellness. Now, it's an unusual way to think about it. If you are adding something to a patient's life, such as contact lenses in their eyes, or suggesting a surgical intervention, that those things could put a patient at risk for having good ocular health afterwards. However, I think that as long as everybody discusses and we're evaluating appropriately before these interventions are added, we have a better chance of having better outcomes afterwards. The aging population certainly is a threat to ocular surface wellness. If you just look at the statistic in the middle of that slide, where in 2013, 841 million people were age 60 and older, and by 2050 it's going to be over 2 billion. That's at least a doubling. So of those patients, if you think that many of them could have been successful contact lens wearers and might fall out of contact lens wear, many of them could have had a comfortable ocular surface and are going to develop ocular surface conditions such as dry eye or meibomian gland dysfunction, in addition to things like glaucoma, macular degeneration, diabetic retinopathy, we're going to have our hands full. We do know that changes to the ocular surface are part of normal aging. We do see reduced tear volume, an increased tear osmolarity, altered meibum in terms of its composition on the eye and directly as it comes out of the meibomian gland, and we do see changes to the tissue. We see fibrosis, atrophy of some of the meibomian glands, and some atrophy of the lacrimal glands. So there is a normal amount of that occurs when we have problems or when this is not consistent with what we would expect in quote-unquote a normal patient. Patients are always taking a lot of medications, you know that. Antihistamines, anti-anxiety medications, antidepressants, diuretics, and oral corticosteroids all have been shown to increase the risk for dry eye, and many patients may be taking more than one of these. Now, they're likely not going to stop taking these, but awareness is part of the issue with patients. If they know that their ocular surface health may be compromised by using some of these other medications, they may be more likely to take a preventative approach in perhaps using an artificial tear or using better hygiene if their eyes look at risk for meibomian gland dysfunction or dry eye. This is a really important bullet. Most eye care practitioners would agree that you know wellness when you see it. So what does wellness look like? Well, it's health. Well, what does health look like? What does ocular surface health look like? Well, it's the absence of disease. How do you define disease? So you kind of can go through these steps in order to define health in our tissues, but our first step is to define normal and normal changes with age. So every time we are doing a comprehensive eye exam, we're evaluating the eye and vision for what would be considered age-appropriate normal. And is this patient in what we would consider age-appropriate normal? Now, over time, we're probably going to have some additional guidelines to help us do that for the ocular surface, but this is a concept that we need to adopt and continue to engage in. The threats to wellness are widespread and affect all ages, and I guess these threats seem scary, but they're common things that we are exposing ourselves to on a day-to-day basis. These should, though, allow us to have early detection and management, and those are really going to be critical in the long term. So routine screening may be an exception to the rule, but why is that? Screenings are a challenge when it comes to trying to figure out if we should be adopting that approach, because they're often not paid for, especially those sorts of screenings that may be considered primary prevention. Primary preventative efforts are not really recognized by our healthcare system, and so it may be that a patient has to pay out of pocket for that. Certainly if you find a disease or a condition, you can code that and go through your examination process, but this is part of some of the things we're going to have to adopt. Now, if the dentist can do that, if the dermatologist can do that, we can probably develop a way that we can do that as well. We certainly have gaps in our knowledge about contact lens discomfort, about the root causes of dry eye disease, including meibomian gland dysfunction. And there has not been any large-scale randomized clinical trial to validate formulations for many of the supplements that we routinely recommend for our patients that we feel are beneficial to the tear film. I have to say that this is changing. There currently is an NIH-funded study looking at omega fatty acid supplementation for dry eye that's ongoing. Now, the results for that study won't be available for a few years, but some efforts to try and answer that question are underway. We continue to explore factors that are associated with contact lens discomfort and dry eye. We alter the materials, we change the solutions, all in an effort to try and understand the factors that impact discomfort the most so that we can address comfort and try and optimize comfort, yet we have a long way to go. The U.S. healthcare system isn't necessarily structured to reimburse wellness, so some of this we might be embarking on a road that we're going to be shouldering some burden. We do know that Medicare offers an introductory wellness exam that includes a vision test if you're over the age of 65, and some insurers do offer wellness incentives, but they haven't stretched as far as to include eye care in that. But I would think that some of the plans that are a bit more on the proactive edge may be willing to consider eye care type of incentives long term. That would be the hope, at least. So advice on keeping eyes healthy is only really covered as it is related to a condition or treatment for a condition. So we will continue have to approach this concept and tackle it so that we can include primary prevention, even early detection or secondary prevention as concepts that we can easily incorporate into our practice and get paid for. Now, secondary prevention, of course, if you find a condition, if you find that they have dry eye, early dry eye even, early meibomian gland dysfunction or contact lens discomfort, all could be diagnoses. Now, how ICD-10 will impact all of this and how willing we're going to be to do these sorts of things and work prevention into our program or into our day-to-day activities will yet to be seen. Behavior change is tough, and behavior change has to be accepted by, at large, the population. Individually, you can work on this with patients. They have to be willing to seek prevention as an option, and there are several things that impact that. Their susceptibility, so they're feeling that they are going to be more likely to have a bad outcome if they don't sort of approach this from a preventative approach would be important. How severe the disease might be or the severity of what could happen if they don't do a preventative approach, and then their own perceived benefit, like sort of a feeling if the intervention would be effective. We don't know, we don't have any data on any of these things relative to what ocular surface wellness might look like. All these things were identified by the group that got together in February as areas in which we need to explore relative to ocular surface conditions. And we all know, all of us have tried a diet, all of us have tried to change some sort of behavior related to diet or exercise or something else. And in trying to do that, you know that you have to be committed. Your patient's got to be committed to do this. And it hinges on some of the things that I mentioned in the previous slide. You don't want it to have to be something so bad or so drastic that they'll adopt it, though. It should be something that you can engage early on, and they should want to do it in order to have the best vision that they can. So they become part of their lives as well as your life in terms of managing them. So what can we do today? The first step we can all do together to walk down this road is to dialogue with a patient about why ocular surface wellness is important. And the important things are the things I mentioned previously: vision, comfort, and or appearance. One of these three things is going to resonate with a patient about why they want a lifetime of comfortable, clear vision with a healthy appearance of their eyes. And if you can get that to resonate with them, then you have made the first step into having this dialogue with a patient. It could start out that you make a note in your record the first time you have this discussion with the patient. The next year at their comprehensive eye exam, you have this discussion in a little more detail and provide perhaps more materials. Perhaps you're listing it on your web page as something that's important to you in your practice. Small steps with patients to maintain their health could be important. Hygiene of their eyes, humidifiers during the winter in dry home or work environments, breaks from computer use, walking around, blink exercises, and maybe it's a little blinky thing that they have on their computer screen to remind them to blink. Taking care of their contact lenses appropriately, replacing them at the recommended times with the solutions, etc., that you recommend as a practitioner. All those are small steps that might maintain good ocular surface health. More routine eye exams, should that be called for if you've detected something early, and perhaps even earlier management of a condition that you've determined is an early stage condition to keep it from getting bad in the long term, are all things that you can do in a small way to help introduce the concept. It's all going to be about spreading the word, and we had one whole group of the meeting that we had in February. One whole section was talking about how we might spread the word and what sort of education awareness activities could occur that are directed both at the professionals, because remember in our manifesto it involved both the professional and the general public as well as the patient. So before they get to you as the public, and then as they've come to you as the patient. And this is going to have to engage professional organizations. This can be a variety of professional organizations, but if we have an awareness of what we might want to achieve together, then we can start working on effective algorithms, models for screenings, models for making wellness a part of a practice, and importantly, a part of practice that can be profitable. We want to make sure that it's a worthwhile endeavor for everybody. These public focused campaigns are probably a bit far off right now, but I can see them eventually occurring. We heard from both the dentists and the dermatologists that public focused campaigns were important in making behavioral change accepted from the standpoint of the public. So to bring it all together, preserving ocular surface health is very important for vision, for comfort and appearance, and that patients can take steps to improve and maintain ocular surface health with our help. Practitioners will continue to play a key role not only in educating our patients, but also in promoting this concept among each other and to the professional bodies that might be able to make change in either how we're paid for these activities, how we can incorporate them into our practices, and how they're accepted. Ocular surface evaluation in terms of health should be part of a routine eye exam, whether you do it in a very small way, in a way that you're already doing and you're just asking a few more questions or listening a bit more carefully. Certainly we know that it's going to be very important for successful contact lens wear and optimal surgical outcomes. Taking a small approach right now to change behavior with our patients may be something that is very important in the long run. And again, this is a long road that we're all going to start walking down together. So on that, I have a list of references here that you could look at or ask to see later from all the references you saw along this presentation. This is a little bit more probably about questions and how you might start to think about incorporating this into your practice than the pure answer of how you really do it, but this is exactly where we need to start, is with awareness on our part and then translating that into awareness on our patient's part and then the public at large. So start talking it up. Go out to your patients and see how they react to these concepts, and then bring them back to me and to others so that we can have a better approach and a more structured strategy. Certainly behind the scenes you should know that Alcon as well as other companies are engaged in this effort in terms of understanding what's behind it all and how we can move it forward, because anything related to behavior change and prevention is a little bit of a, a tough place to be, but we all really feel in moving forward it's very important. I appreciate all your interest tonight, and thank you for listening. If you have questions, feel free to type them in, or I'll answer them as we go forward.
All right. Well, thank you, Dr. Nichols. That was great. And as she just mentioned, if you got questions, you see that little box on the right side of your screen. If you've never been to one of our webinars before, you know you can type right into that box, and your name will not show up for the public to see, so don't be bashful. That's why the box looks empty on your screen right now, because you can't see what other people are typing. So if you have questions or comments, feel free to type them in. We're getting a couple in right now, and Kelly, I think I'll just pass them on to you all verbally. Shout them out, and then maybe you can give me some feedback. So, question here. When you evaluate your patients, do you use one dry eye questionnaire or a combination of a few validated questionnaires?
I see this is from Leslie. Hi, Leslie. In our practice, we tend to, with the students, you have to recall that I'm in a teaching institution, so we want to expose them to a variety of different things. We've routinely used the OSDI in practice because you can get a number, but I find that verbal questioning is perhaps in our environment one of the more effective approaches. So I'll use the screening test of the OSDI, the Ocular Surface Disease Institute, which was developed by Allergan, to kind of get an idea of where they're at, and then through questioning, I feel like I get the best information. Now there are a few other surveys that are being developed specifically for contact lenses comfort and for meibomian gland dysfunction, yet none of them are really easily usable in clinical practice at this point. So I just think that using the same approach and technique to asking your questions over and over, and then following up on your answers, making notes of them in your record and following up on those is perhaps the best approach. Now, there is an initiative going forward that's sponsored by a number of industry groups that's looking at how to come up with a screening survey for the dry eye examination, and what surveys are routinely used by dry eye practitioners who are out there doing this already. This is an effort that is ongoing and really is going to start in earnest in December and January December this year, January into next year, and with the hopes of developing surveys and providing a platform where a variety of different surveys that are used by different practitioners can be posted, so you can kind of take a look and pick from among those for yourself.
Great. A question here. You mentioned a few slides back that there was a large study looking at omega-3s and the impact of supplementation on the tear film. Are you aware of any other studies going on with other sorts of supplements?
They're probably, well, to be honest, I know that large study, and there are a few different companies who have some, who want to have an eye claim relative to their supplement, who are probably doing some smaller scale studies. I have heard of a few in the past that have been done. We have actually done one ourselves, and it really all depends on how you design the study, to be quite honest, and what your outcomes are, because the outcomes that you see can be quite broad. Sometimes in one study, if it is an open label study, you have improvement in everybody, and then if you do a placebo control, picking your placebo control is really important, and that's the hard part in an omega study. So I think that the approach that is going on in this large-scale study is to use a placebo control, the same one, and look at a whole variety, a whole host of procedures that are being performed, and following these patients for a long enough period of time to see if there's a difference will make an important difference in our knowledge base, because I feel like most of the studies that have been done to date lack something in the design or in the control or in the patient population, to be quite honest. So there's a lot of data, but not a lot of good data out there.
Right. What would you recommend that someone does at this point, in the absence of having really, in the meantime?
Yeah, in the meantime, most recommendations I hear, without knowing exact, what would be the best dose, would be at least 2 grams of omegas. Try to get something that's as purified as you can. And, sometimes the more expensive ones are a little better. Being consistent with it and taking it every day is probably the hardest thing to do, because people will do it for a while and then fall off the wagon or run out of that bottle and then quit. So I think that, for now, it can't hurt to take 2 grams a day of nearly any of them. Of course, there's arguments, should it be this one or that one, or processed this way or not the other way, and I'm not here to get into that argument tonight, but some is better than none, and I think that most patients who do use it and have some beneficial effect notice when they stop taking it that they've changed, and so then they'll go back on. I do notice that myself. So I think that in the meantime, keep on what you're doing, keep on with what you're recommending, and and really listen and ask your patients about their experiences.
Right. Clinical question here. Is there any thinking that routine lid massage should be promoted to prevent MGD rather than only as a treatment of existing MGD?
Oh, that's interesting. It's hard enough to get patients to do home therapies for MGD as it is. I've not heard of any thinking that routine lid massage would be helpful. And, of course, there's emerging data on some of the technologies like the in-office treatments. Now there are 2. There's the LipiFlow in-office treatment, and then there's also a device that actually has a little plate that warms up that you can actually use to massage around the eyelid. Both of those might be very effective at warming the lipid secretions in instances where there's some blockage or some stagnation of that lipid. What we don't know is long-term what that sort of massage might ultimately do to either eye pressure, the eyelid, or any of those, or the glands themselves. I can throw a cautionary note that in some of animal studies that our group had done on meibomian gland expression, if you squeeze terribly the eyelids of mice, now these are tiny little mice, and you have some damage to the you see some damage to the meibomian glands even though you were just using forceful expression. What does that translate to in our world? It makes me wonder whether or not consistent use of expression of the meibomian glands as a therapy, a forceful expression of meibomian glands as a therapy, might not actually be an induction of irritation that could lead to some scarring or dropout. We just don't know. So I would say that massage, just as the regular massage to your back or your shoulder muscles, can be a good thing. If it is too forceful, it perhaps could be a bad thing. Again, this is all without any data to support that. So routine lid massage that's of gentle enough nature, routine massage that includes warmth, I can't imagine could be bad. It's just like everything, probably in moderation.
Right. Well, we're just about out of time here, but it sounds like we're in the early stages of ocular surface wellness. And thank you so much for sharing all this with us tonight. Do you have any parting thoughts for us before we go?
If you have a question for me you want to address that I wasn't able to answer here, my email address is nicholsk@uab.edu. So feel free to reach out to me if you have a question. I think that, again, we're on the very early stage of walking down this road of prevention and ocular surface wellness, but it is really a concept that resonates with me, as I hope it does with all of you. I hope all of you have a wonderful evening, and thank you for attending.
All right. Well, thanks everyone for being out there, and I'm sure the conversation will continue on ODwire. Thanks again to Dr. Nichols, and thanks to Alcon, and thanks for everyone for being here.
Yes, thank you, everyone.
And I guess we will see you all online. Good night, everyone.
Good night.